Hello, and welcome back. My name is Francisco Gutierrez. I'm a Senior Vice President for Medicine and Health Sciences for Laureate. I want to start quickly by thanking IntraHealth for inviting me and Laureate to be part of this conference and actually have an opportunity to share with you some of the things that we do at Laureate and that hopefully will be of value to everyone attending this conference. I have also want to start saying, but for those of you that don't know Laureate, we are the largest network of private universities around the world. We have 72 institutions, and we actually provide degree granting, mostly education, to about 800,000 students located in every continent. I have also the opportunity to hear about some of the speakers before, and some of that will be related to what I'm going to talk about, which is how we do global education. And before I share with you some of the examples of how we're doing this in terms of educating health professionals for the world, I want to make sure I don't forget the key points that I want to leave with you. First one is about the shortage of health professionals, which is a massive problem, and it's so critical that you need to come up with solutions that, in a way, to solve it, you're going to have to work with health sciences education at the different levels. The solutions that you provide for the critical shortage will have to be for a different healthcare professional, as you know, is needed today. And on top of that, now we have this understanding that these health professionals need to work together. So that makes the things more challenging. The second point I want to leave with you after showing the example of how we do it is that to do this, you have to basically transform the pedagogical approach of doing things. And to do that, it requires breaking up with tradition. And if you're familiar with how hard the traditional universities work in maintaining the traditional way of teaching and learning, it's very hard to do it. To challenge the tradition, one of the facilitators will obviously be technology, and I'm going to show you some of the things we do by bringing technology to challenge the tradition. And basically, again, you need to make sure that whatever your product is, it's a health professional that is apt to work together in an interprofessional setting. Also, outcomes are important. For us, many of our students are the first ones to go to a university, so employment, it's a big outcome, a big aim of our universities, but also, obviously, technical knowledge, and ultimately, patient safety. And the final point I want to make sure today I convey to you is that you need to match these learning needs with the right resources. And that, of course, we're going to have to change the curriculums, and changing curriculums is harder in traditional universities, easier for us because our universities are more agile. Transform the learning environments and also the clinical learning environments, which haven't been changed in a long time. So the problem is big, the critical need is important, and in our opinion, you need to strategically change the way you train health resources, because you have to do it fast, effectively, and ideally efficiently, because the solutions are needed very soon. So I want to share with you some of the things that we do, and I like to start with the first example, and I know this is not related to healthcare, but hopefully it'll be, when I'm done with this, they'll make some sense to you. This is obviously the famous landing in the Hudson River a few years ago by the crew and the pilot of this airplane, and many of the things that we're learning now apply, because this was a success story, that are coming out of the aviation industry, obviously need to be applied to healthcare, because we have demonstrated, as seen by the original 2001 Institute of Medicine report, what we do in healthcare is not exactly safe, and we need to learn from other industries how to do it safely. And this was an example I want to come back later. This is our network in health sciences only. As I mentioned a little bit about Laureate, but in terms of health sciences, we operate in 35 universities in 17 countries, and we train about 160,000 healthcare professionals, mostly degree granting. We have 17 medical schools, 21 dental. We also have veterinary. Of course, 25% of our students are in nursing, all levels from technical to postgraduate. We have occupational therapy, nutrition, physical therapy, all sort of professionals we train around the world, and we do it with a very unique, what we think, model that I think is the focus of my presentation today. I'm showing you the example. You see here what we call our learning model, and what you see on the right is really, I'll talk about it, the competencies of healthcare professionals. There's a tremendous focus on competency-based education. We think for health sciences is very, very important because of the critical need and the need to do it fast. So competency training at the international level is important. Of course, superior student outcomes, whatever they are, mostly again related to employment. Have accreditation is important, and eventually, since we are in healthcare, whatever you do will impact the society and the communities where you are. In the pie, you see 5 pieces that are part of our learning model. I'm going to just focus on 2 of them because of time, but hopefully I'll have a time to share with you some of the other things that we do. Basically, I want to touch on that pink slice that talks about the new human and animal structure and function, which is an example of how we now teach anatomy and physiology. Also focus in the blue segment, which talks about simulation labs and methods, and I know there will be a micro lab with one of the largest manufacturers and one of the innovators in simulation in medicine, which is Laerdal, which is here with us, running 2 of the micro labs, and I hope you all have a chance to see some of the things they have for us here to show, and we work a lot with Laerdal around the world. So I'm going to focus on those 2. And this is basically the way medicine is taught around the world in the traditional universities. Very romantic, the same way, do it with the cadaveric training and the Rembrandt picture and everything, and working like this for about 120 years. The same way. Most of the schools, if you walk into a medical school, they'll show you this. And the problem is that the physicians today work with this. Which is very different. It's not exactly what they learn in school. Again, going back to, are we looking at competency level education where you're really wasting your time in other things that may be traditional or romantic, but not necessarily contribute to your learning or the needs that you're going to use in the future, which is this kind of technology in imaging and other areas. This is the kind of surgery now that we're doing with Da Vinci and other devices, and we keep training with opening a rabbit or opening a frog and trying to teach our students for 2 years how to do that, when the students for the rest of their lives will probably be using these kind of tools. So some of the earlier examples that influenced our model came from Stanford. This is 2003, what they call the SMILE project, Stanford Medicine Information Learning Environment, basically looking at what they call the ecology of learning and how students learn, and an emphasis on action and immersive visualization, how to be immersed in learning so you can learn better. And this really transforms the way your labs are set up and everything. Again, very difficult to do in traditional universities because labs are turf territories for people and very hard to learn. And then you have things like this, which is the Lancet report, the Health Professionals for New Century, led by Frank and others at Harvard. But basically, it's dictating the policy in terms of health education and the importance of linking the health systems of the world with the health education at universities and other levels, and saying basically adopt a competency-based curriculum, use IT for learning, and basically again work in teams and make sure that the students work together so when they graduate they also work together. All of those influence our system. This is some of the examples borrowed from some other universities at the beginning of how we teach anatomy, and we basically try to make our schools teach anatomy with live subjects. So we use body painting, body projection, body surface anatomy, something that makes the students learn in a relevant environment, something where they feel more attuned to what they're learning. and really make it significant versus the traditional way of doing it with cadavers and other areas. And we do this for everyone. And then you can use technology. This is a virtual dissection table, which is available now in the market. You have different variations, but basically the student can work through the different parts of the body and doesn't have to be exposed to risk or anything, or the high cost of maintaining the wet labs like traditionally are done. So some of our students, this is again going back to the Stanford concept of immersive environment. You see the students working with different tools, tablets and models and interactive groups, etc. And they're in an immersive environment, hopefully acquiring the knowledge that is, again, relevant, very much related to clinical anatomy or clinical physiology. It's another example where there are 3 ways of learning for the respiratory system. You have a little bit of body painting there, a little clinical anatomy, to some of the computer upper left teaching the physiology of the respiratory system. And in the bottom you have the virtual histology, which is another romantic notion of having microscopes. You know, I tour about 20, 25 schools that are candidates to join laureate around in the world. And the first thing they show me after the cadavers, of course, is the microscopes. And they go after room and room and room of microscopes, and they're all proud of showing the microscopes. And I keep saying, you know, how many doctors use a microscope after they graduate, or how many nurses? Microscopes are not needed to do your work, and very few will use them later, unless they're a pathologist, or of course they have to do with things. Most of the US schools have eliminated microscopes, so that's not the truth around the world. You need to learn histology, that's truth, and you learn it with a virtual atlas, which is primarily free in the internet. The other thing is about simulation. This is also a tool that we use a lot. These are our labs. Our labs look like hospitals because we believe that the students need to be in an environment that are realistic and their learning will be more significant. So when you walk in the left, you basically are entering a hospital, but it's really a lab. It's a virtual, or let's say it's a simulated hospital. To the right, you see a number of patients. Some of them are mannequins, some of them are actors, some of them are a mix. Basically, our nursing students are there from the first day. They can see and feel how they're going to be trained. Our labs are multidisciplinary, no more. You know, I also walk around labs around the world, and every professor has a key for their lab, and this is my lab, this is how I teach, and it's used probably once a week or twice a week. It's tremendous waste of resources. Our labs are now mostly dry, as you can see. They're flexible, they're multidisciplinary. You can use them anywhere. In the bottom, you see what it can be: an intensive care unit, an emergency room, an operating room, anything. The students are in this side, they have a way to see what's happening. In that case, it's a high-tech simulator. Not necessarily, you can do anything in the other side. But this is very different kind of training, and it's being very, very, the reward we get is from the students that are very satisfied and I'm really learning a lot. And you have high-end and low-end simulators. In the top left, you have a simple pelvic simulator for pap smear taking, and what you see is the teacher in the back, supervising the student. This used to be done with usually poor patients, so your first pap smear will be with a poor patient, and then until you practice enough, then you feel that you're competent. But in this case, you have the simulator training you. You can repeat, you can make mistakes, you can be supervised, and not until you're assessed that you're proficient, you can be probably then sent to a real clinical setting. In the right, you see a virtual delivery, a vaginal delivery or a seed delivery, which we can now replicate exactly, create complications or put the students under stress. So when they go out, they're much more competent and able to really perform better. And some of our nursing students look like medical interns when they're in their 4th or 5th semester because they feel so secure about what they're doing because they've been in this environment. These don't necessarily need to be costly. There are high-end simulators. You'll see some of them in the microlabs today. There are also low-end simulators that are very helpful. What's different is the methodology and the way that you work with your clinical teaching staff to do that. Then you can go into things like this, trauma and motor vehicle accidents, big killer in the world, right? Well, then we do these kind of things, which is a technique called moulage. It's also simulation. You create these scenarios, the students are exposed to this, and they have a series of learning objectives and checklists, so you make sure that the students are learning, and they face this in a simulated environment, which seems realistic. It's all realistic. The student, when they go to the real world, they really feel much more confident, and they can go through a checklist of processes and systems to make sure they do it the right way. And the right, some of our veterinary schools doing some of the student body painting things with the models, which helps them a lot to understand what are the important parts of the anatomy. Again, going back to the new anatomy system. We have some other complex scenario. Again, the ability of the students to work together. In the left, upper left, you see students working together from 7 different professions in a hospital ward. This is really chaos, but it's really got like the real world is. So the students need to go to different interactions. There may be 15 or 20 patients. There will be a waiting list. There will be a crisis, an energy break or something. And the students need to go and react appropriately. They'll be assessed and really monitor their performance and then talk about their performance. And you see complex simulation in the bottom, and then to the right, where you see the use of high complexity simulators. And these are our labs again. We're moving from microscopes and calibers to real simulated scenarios, which is really amazing and very much what's happening around the world. This is a dental simulator. This is not ours. This is BCU in Virginia. It's a very high-end dental simulator. Dentists have trained with simulators for a long time, but they're mostly skill-based. This is a new system from Israel. It's amazing. It's really virtual dental work. They do it in the computer. They can know exactly if their ergonomics are correct, if the depth of the perforation is appropriate, and if the patient is being or not cured. So basically, the teacher has a very little role there other than supervising or facilitating, because the computer is setting up the learning objectives for the students. Very, very interesting work in terms of dental simulation. So we always focus on this. This is a medical student and nursing student in one of our Brazilian schools, and we always ask this, is this student learning? And or this student learning, the two of them are, this is a plastic baby, right? This is all creative, but when you see the faces, and again, we train more than 150,000, you know when the student is engaged, and these two students are very engaged in what they're doing. Everything is like the real world, and what's important that we know that they'll be competent, and this simple scenario probably is testing, about 10 to 12 competencies from knowledge to attitudes, to behaviors, etc. And it's very, very helpful and definitely has an impact as being relevant to the student. And why do we do this eventually? One of the lessons from this problem in the Hudson River, it's a lot of follow-up stories and books written about it, but some of the things that caught my attention was the interview with some of the crew members, and the purser, the lead crew flight attendant said that, why is it that you were so successful in rescuing all these people and avoided more than 150 deaths, etc.? And she said, this was easy for us because we have done it before so many times. It had never happened before, but they've done it before so many times. This is when I go back to what do we have to learn in healthcare from other industries. Aviation is one, and what they've done is simulated this situation. So when the problem occurred, it was quickly a quick reaction by the flight crew to know exactly what to do, how to move the passengers, etc. So it's all about patient safety, and hopefully we can learn from this. And simulation has been a long story in aviation, and hopefully in healthcare will contribute to a lot. So those are some of the examples. Hopefully it'll give you an idea of what we do at Laureate and some of the things we're doing in healthcare. We have shared responsibility with some of you as organizations. We probably operate sometimes in different countries, but we do the same thing, which is helping hopefully solve some of the shortages around the world with good quality production of health resources. Thank you very much.